Okay, thank you, Sabine, and thank you, Eric, and the organizers of this conference for inviting me. I'm going to be talking, as you heard, about a neurobiologic perspective, but one that very much includes psychosocial models and treatments. And as a framework, I'm going to talk about the implications of validators for diagnostic classification. But I think more importantly, I'm going to talk about how this kind of combined perspective can help us move forward in the field of personality disorder research. And what do I mean by that? Well, of course, we need to have a much better understanding of their etiology. We would like to spur the development of more effective treatments, both psychopharmacologic and psychosocial. We'd like to be able to predict for people what is the best treatment. In other words, who will respond to which treatments. There's quite a bit of heterogeneity within the personality disorders. We'd like to parse that out in some kind of rational basis, which is certainly part of the diagnostic task of our treatment manuals. And I will try to address too continuity and discontinuity between normal and personality disorder traits. Are they on a single continuum? Are there emergent properties, or are they distinct? So these kind of models can help us move towards gathering data that'll be informative for these important questions. So a neurobiologic psychosocial model, which accommodates both aspects, accommodates individual differences at a genetic, epigenetic, early developmental level, interactions with psychosocial developmental tasks, a framework for new interventions, and can help us identify individual susceptibilities and validate diagnoses, resolve dimensional and categorical dichotomies. So we're talking here in terms of what we know about some relatively broad but characteristic temperamental vulnerabilities, affective instability, for example. Sabine mentioned aggression. And we're talking about psychosocial factors, some of which are broad, likely to have profound significance in all domains, abuse and neglect, for example, but of course the very highly individualized psychosocial factor that gives each individual its identity. And I also then want to say, well, can such models help us address some of the issues raised by DSM-5, which was quite controversial, ICD-11. Some of the issues, I'm not going to go into detail in these. Excuse me. Traits versus categories, you've heard a lot about in this meeting. I'm going to touch on that. Metastructure issues are very much affected, how we organize our diagnoses. Clinical utility, of course, is critical, can't necessarily be addressed by external validators, but I'm going to focus on these kind of external validators. That is, measures that come from outside of the psychometric measures of the criteria or diagnosis themselves, but from domains like neurobiology, psychosocial antecedents, treatment response, that might help us carve out what are the really germane ways of dividing these disorders. So I'm going to talk about the framework in terms of some basic psychologic dimensions, affective instability or regulation, how somebody regulates their affective responses to their environment, impulse action patterns, what is the threshold to action, particularly aggressive action when provoked, attention and cognition, how cognition is organized, anxiety, fearfulness, and avoidance of potentially threatening stimuli, and the interpersonal domain in terms of affiliation, trust, and separation distress. So the domains of validation that were adapted for DSM-5 were temperamental precursors and environmental antecedents, which address the developmental precursors of these disorders. We want laboratory behavioral paradigms for research because we would like to be able to objectively measure some of these characteristics that we observe naturalistically in a controlled setting where we might not naturally observe the behaviors which occur only in a specialized context in which the individual lives. Genotypes, biomarkers, course, treatment response. So I'll be looking actually at each of these domains with regard to some of the main dimensions that I mentioned earlier, just to see where we are, what we can learn, how they can help us with the things we need to know I brought up at the beginning, and give us some insights into diagnosis. So we know there are limitations of validators. Obviously, we can't select a classification system alone by validators. There are too many ambiguities. There are too many alternative systems that might meet available evidence. We want to use categorical versus dimensional validators. They both may be useful in different contexts. I will talk about both. And the clinical utility by itself, while should be convergent with the validators, is not necessarily a sequelae of actual validation with other measures. So that has to be kept in mind separately. And of course, we use research strategies which range from assessment of the sequelae of trauma, neuroimaging, cognitive neuroscience strategies, candidate gene, and some of the newer paradigms from affective neuroscience and social neuroscience, which I'll be talking about at the end. So starting with impulsive aggression, that is a low threshold or low fuse for the release of aggression on provocation. We know something about the circuitry, the neuromodulators from a neurobiologic point of view. We know that cortical regions, particularly frontal cortical, orbital frontal, and cingulate, which are involved in affect regulation, action regulation, experience of self, judgment, are critically important in modulating or dampening limbic regions that are reactive to the environment, such as amygdala, insula, and that lesions of cortex, adaptations or differences in volume, processing efficiency of these regions, in fact, we can document have an important association with some of the aggressive behaviors we see in our patients. And there are neuromodulators, serotonin in particular, that can modulate or reduce aggression. The catecholamines may enhance it, and GABA-glutamate balances, which are critical in limbic regions. So over the course of development, we can see how any of these dimensions will have important influences on how the individual accomplishes critical developmental tasks. And not only will these dimensions affect the resolution of each critical role in development, but that the resolution of previous levels will affect future levels, so that, for example, a very aggressive, high-activity infant with a lot of tantrums can interrupt attachment between the primary caregiver and the infant, and this can actually set a less secure foundation for separation and individuation, where at the same time, the role of unrestricted aggression can lead to more uneven and conflicted separation, so that previous effects in attachment and then effects specific to the separation phase may be critical for aggression. And then this can lead to ambivalent identifications and stormy, turbulent relationships during later periods, so that indeed these dimensions act throughout development. We can see temperamental precursors for this dimension relatively consistent across the lifetime. Child temper loss and aggression predict adult aggressive behavior in study after study. And indeed, we can see some of the biologic findings I'll be talking about in younger subjects. In this case, some work of Mary Ann Goodman in our group looking at anterior cingulate cortex in relation to suicide attempts in adolescents with borderline personality disorder, with smaller volume on the left there being, I don't know if this actually works, but smaller volume being associated with greater suicide attempts. So we can track these neurobiologic precursors earlier in life than adulthood. And of course, we know that there are effects of abuse and neglect. For example, in studies we've done, we found that sexual abuse and physical abuse are strong predictors, actually most of paranoid personality disorder, which is understandable, not specific for borderline, although it's present in all the personality disorders, and antisocial particularly, and emotional abuse independently predicts suicide history. Now, we'd like to have some kind of laboratory behavioral paradigms, as I mentioned, so that we could reliably, in fact, measure some of these predispositions to aggression. One of those paradigms is the point subtraction aggression paradigm developed by Don Sherrick in Texas, where a subject actually is seated at a computer screen. They're aware there are other subjects in remote areas that are not visible to them. They have to press an A or a B button. A button, they get a point. So really, if you accumulate points, which they trade in for small change, then pressing the A button is the rational behavior. But you can press a B button and it gets you nothing, but it does take points away from other participants. So in this game, which is actually a simulation or deception, the points, there are really no other confederates. The points are taken out periodically at a program that's determined by the operator of the computer. The more points are being taken away, the more likely someone is to press the B button and take points away from other people because they're provoked. So indeed, there is a relationship between the provocation-free interval, the interval time that they're not having points taken away, and the number of B button or aggressive responses that they make. So more they're provoked, the more they're aggressive. And that slope you can see in the red group, the group that's borderline positive, is much steeper. They're much more likely to engage in aggressive behaviors. And in fact, in currently aggressive individuals, who we recruited for some studies, these people are always pressing the B button. They go right to it. They never press the A button. They earn no points, but they do express a lot of aggression. And maybe that's just New York, but it is something we do see in some of the more aggressive individuals. And we can define genotypes. Again, what I'm trying to do is give you an example rather than say, this is the definitive story. We know the genetics of it. We know the neurobiology, but just the inroads we've made in defining some of these validating factors. TPH2 is a rate-limiting enzyme for the synthesis of serotonin. Serotonin is very important in modulating prefrontal regions, which provide the inhibitory brakes to limbic provocation via amygdala that are the sort of sparks that drive the impulsive aggression. There's been identified a risk haplotype, that is a group of genes that increase the risk for suicide, and this is in a Scandinavian sample that was examined in our borderline and other personality disorder patients. And we found that the risk haplotype, which is represented in blue, that provided that risk in that previous study for suicide, was more prevalent in borderlines compared to the non-risk haplotype in the red than it was in the healthy controls. And we also found a dimensional relationship with impulsive aggression as rated by the aggression inventories we administer or by our laboratory tests. Excuse me. Interestingly, when we translated this into a PET paradigm, where we use the PSAP we talked about to look at gray matter activation, how much of the frontal lobe is activated during this provocative task. Normally you would think that frontal gray matter would be activated to provide the brakes on the amygdala and other limbic regions as the individual is provoked. But we could see in the green, those are the individuals that are homozygous for that risk haplotype that conferred a greater risk for suicide. They, you can see on the left, have the least activation of gray matter of neurons in the frontal lobe. So they're much less able to recruit these frontal control regions. Now, another potential variability in individuals, between individuals, is cortical volume of developmental sources. Here we can see the anterior cingulate, that critical emotion control region, is actually reduced in volume in borderline personality disorder patients on the right compared to controls, both in left orbital on the left and right anterior cingulate. So we can see that variability in brain structure can be related to this enduring dimension of behavior. We can look at activation during this task, the PSAP, and provoked versus non-provoked situations. This is work of Antonia New and Aaron Hazlett, who did the previous structural MRI, and we can see that in most frontal regions, actually less activation in the borderline personality disorder patients in red, except for orbital frontal cortex, where we surmise that increased activation actually may reflect inefficient processing in this region, so that there's less efficient controls. You see a sign of turn-off on some of the sensory areas, occipital, parietal, a kind of withdrawal, if you will, from incoming sensory stimuli as they get provoked. And of course, a huge reaction on the right in the amygdala, the red bar and the borderlines far outweighing the controls. And of course, this is consistent with a lot of data, Sabina's data, and many other groups showing this amygdala hyperactivation in response to provocation. We know that serotonin can modulate this system. It seems to preferentially modulate certain prefrontal regions, such as orbital frontal cortex. Fenfluramine is just an agent that pushes out serotonin, and normally it enhances activity in certain regions, particularly the frontal control regions. But you can see, and this is looking straight forward on the right to the skull, those, you could see where the orbit of the eyes are. That region of orbital frontal cortex that the arrow points to is underactivated in our aggressive patients compared to controls. That is, the serotonin is not so effective in modulating that region, leaving the individual presumably vulnerable to overactivation of amygdala alarm arousal systems. And we can see this with another agent that modulates serotonin, MCPP, which acts directly on receptors. And what we see here is that if you look at our controls, they increase activation in these frontal regions in the blue from MCPP, the active substance, to placebo, but actually in our patients, there's a modest decline. They're not able to use the serotonin to modulate their limbic systems. And we can actually measure components of the system, one being the 5-HT2 receptor, which can be actually labeled specifically by an MDL compound. And we see that people with current physical aggression have greater 5-HT2 receptor number than those without aggression or controls. And in fact, this is interesting because animal models have suggested that the 5-HT2 receptor is a critical modulator of aggressive and impulsive behavior, in particular in animal models. So we wonder if, in fact, antagonists for the 5-HT2 receptor, and I'll come back to this, would be helpful for this disorder. So it may generate a treatment. We can see over the life course that there's a modulation or a dampening of the impulsivity that's in the lavender and the intense anger of borderline personality disorder. Of course, it goes down in conjunction with many of these other dimensions of symptomatology. So there is a course to it. Again, another one of our domains of validation. Treatment response. There's an early study of Emil Coccaro showing fluoxetine and SSRI, which can enhance serotonin, reduces impulsive aggression over 12 weeks. There have been other studies showing that. And we can show, this is work of Antonio New, that orbital frontal cortex actually is activated. So the SSRIs, in fact, are bringing the frontal control regions back into play so they can be effective in modulating those aggressive regions. Now, these are global effects. They don't affect necessarily learning about individual responses to provocative situations, but they provide a baseline shift in the responsivity of these systems. DBT is another psychosocial treatment, cognitive behavioral treatment, that actually can reduce aggression in questionnaires. This is a study of Marianne Goodman compared to controls. This is the treated group is in the green, shows a steep drop. The untreated patients, no change. And we have been studying patients on fluoxetine, looking at that 2A receptor we think is critical to modulating impulsive aggression, and found that over time, fluoxetine actually downregulates the 2A receptor, and that's proportional to reductions of aggression in our pilot study, which we're now completing in a larger series. So that increasing presynaptic serotonin, downregulating that 2A receptor may be helpful in modulating aggression, which generates the possibility of new interventions. For example, if the 2A receptor is more active, then 5-HT2A antagonists may be helpful, so that we attack this postsynaptically as well as presynaptically. There may be decreases, at least in animal studies, with a complementary serotonin receptor in aggression, the 2C receptor, so the 5-HT2C agonists are also of interest, and we're beginning to explore them as well. So what about affective dysregulation? We talked about that, and of course, that's a hallmark feature of borderline personality disorder that accounts for much of the drama. Interpersonal turmoil is highly correlated with suicide threats, identity disturbance, emptiness. And really here we're talking about that emotional hypersensitivity of the limbic system, of the amygdala. And again, this emotional sensitivity, this in the course of development, the hard to comfort infant is going to have a less secure attachment, have trouble with separation and individuation, fear of abandonment, and independence, clinging, hostile relationships. So obviously this dimension could have important developmental consequences in psychodynamic and developmental terms. We have temperamental precursors in high novelty seeking and high harm avoidance patients. Child maltreatment, of course, and maternal separation, in fact, make it more likely to have this dysregulation. We have found genotypes. This is one that you may hear more about from Antonia New and Mercedes Peresosa, but the opioid receptor, which is critical in modulating affective distress and separation, self-soothing behaviors, is actually associated with affective lability in one case. We don't know its functional significance, but just to show that we're beginning to get genotypes that actually track with the affective instability. We can use laboratory behavioral paradigms, again, to elicit certain kinds of phenomena like affective dysregulation in the laboratory. This is a startle stimulus response in response to, on the left, benign stimulus, Barry Brazelton, a distressing stimulus. And this is work of Harold Koenigsberg, who will be talking more about this in the afternoon. There's more recent work that there are clusters of different activation to negative scenes versus rest. And these are like the amygdala, which is the critical alarm region, middle frontal cortex, which is involved in representations of self and affective self. Fusiform is a facial region. We've been able to use, and Aaron Hazlett has piloted this affective startle modulation for borderlines, where you can actually potentiate a normal startle response if it's administered during a provocative stimulus, like an unpleasant word or unpleasant face. That potentiates, as you could see in the bottom, normal startle response, which is a burst of white noise provoked startle. And negative borderline salient words would be like abandon, alone. Neutral words can be contrasted. When you administer the probe during unpleasant stimuli like hate or lonely, as opposed to neutral stimuli, what you can see, looking at unpleasant words as stimuli on the right and on the left side where it shows startle, in the borderline patients in red, they have a much higher startle response when the probe is administered during the unpleasant borderline salient words. But this difference doesn't occur with neutral words or in other paradigms. Pleasant words. Interestingly enough, patients self-report of their behavior valence for the stimuli is actually lower. In other words, their physiology is reading, they're alarmed, they're upset, but subjectively, they don't report it. They report less than controls. This disjunction may mean lesser identification of emotion, emotional numbing. There's a variety of ways to explain it, but I think it's important to note. Also, if you look at these affective startles response, you can find that over time, normally people habituate to it. So you can see in the blue, healthy controls, between 2 time periods, the response decreases. But in our borderline patients, and you can see on the panel to the right, with the unpleasant stimuli, this ramps up. There's a higher response. So instead of dampening in response to repeated stimuli, they actually ramp up or rev up their response to repeated stimuli. And much like you can see, I think some of you in therapy in the clinical setting where there's sort of a revving up of response. Normally, people increase anterior cingulate activity, this is work of Harold, when habituating. That provides the controls normally, but borderline patients and avoidant patients do not. So they're not able to recruit these frontal regions. And the healthy individuals, you can see in the blue, they deactivate the amygdala when distancing, using strategies to distance themselves from the stimuli. Borderline patients can't, and you'll probably hear more about this from Harold. And again, the course of the affective instability on the top is a declining course. These volatilities seem to dampen in the course of age. So there is a characteristic course. Treatment response, we've had some new data. We had some promising results, some work of Marianne and Aaron Hazlett, that responders to DBT showed deficient amygdala habituation at baseline. In other words, they don't dampen their response with repeated stimuli. It's a general characteristic of borderline, but particularly the non-responders. Particularly the responders. The non-responders have, you can see on the right, variability of the response. Some of them do dampen, some don't. So, in other words, it's the people who can't or don't regulate their emotions so well that do respond to a treatment targeted to re-regulating emotions. And this might be important and helpful in thinking about who's going to respond to DBT. The ones who may not probably are higher, as we look at it, in dissociation. They may not even have the amygdala hyperactivity because some of the dissociators have actually dampened or lower amygdala activity. So here's a physiologic marker that might help us predict response to treatment. And here you can see the unpleasant stimuli, a DBT responder with a green arrow there showing actually decreased amygdala response after 12 months of treatment. But the non-responder below, you can see in the open circle actually increases their amygdala response over the 12 months of treatment. So we have a differential response here. This is potentially exciting. We're pursuing this in terms of being able to predict treatment, understand better mechanisms that are involved, the physiology that affect this important psychosocial intervention. What about interpersonal affiliative systems, trust, separation, tolerance? You'll hear more about this from Antonia Mercedes later today, but the neuropeptides, opioids, oxytocin, modulate orbital frontal processing. Other peptides modulate the amygdala, the insula. And these are very important involving approach avoidance, attachment, trust. So that, for example, here in work done at Mount Sinai a while ago, Jennifer Bart's looking at response to cooperation in a game where you can either cooperate or defect. Oxytocin actually increases or moves people to the cooperation side. You can see they're lower on the line to the left, in the red, but in the borderlines, it actually increases the likelihood of defection. So it's if there's exaggerating a mistrustful response, they have at baseline increasing salience. I'll talk about this in a little bit later. This is the movie to assess social cognition that Mercedes has developed using in our laboratory. And we can see there's two kinds of errors of it. This is a movie to assess how people interpret others' behavior. Some over-interpret and distort. They hypermentalize. You can see in the light green, the borderlines are the ones, the borderline adolescents, who make the most hypermentalizing errors. Hypomentalizing errors are sort of under-interpreting more concrete responses, and those, the blue and the red, which is the schizotypal and the schizophrenic samples, are the ones with the greatest hypomentalizing response. So there are different kinds of distortions of mentalizing, and maybe we can understand the effects of peptides like oxytocin in terms of baseline differences, which is critical, I think, in thinking about treatments. Opioids mediate not just physical, but also social pain and social exclusion. And we've presented a model where, in fact, there's a less baseline outlet of opioids and increased receptor number as a baseline state, so that when individuals, for example, cut themselves, put themselves in painful situations, they may feel a relief as opioids hit those supersensitive receptors, but at baseline have a chronic dysphoria and anhedonia, some of whom describe relief when they're put on pain medications for various reasons or back injuries. So that this is a viable hypothesis that would potentially respond to a partial agonist like buprenorphine. There are other agents coming out that are being developed that might be promising agents to address this kind of potential deficiency that we're looking into. The opioid OPRM receptor, which I mentioned earlier, also is involved with interpersonal and social cognition, which you can see the pattern is highlighted by a history of trauma. So the trauma, the psychosocial influence, interacts with the genotype to give you, in fact, more borderline behavior. And we can also see difference in activation patterns in the PET with the PSAP, with the provocation we talked about. So this affects functional activity. And then finally, oxytocin, which you'll hear more about, can modulate the amygdala reactivity to social threat. And it attenuates amygdala response to betrayed trust. So possibly this is a modulating dimension in the interpersonal realm. There is a risk haplotype that's been identified that leads to higher aggression scores. You're going to hear more about this from Mercedes, so won't talk much about it, but it's also related to anxious attachment. And there are also protective haplotypes. This is one which guard against or mitigate against these kind of reactions. So one question is, how does oxytocin work? Mercedes is in the midst of some experiments to see if people with hypomentalization and people with hypermentalization, that is exaggerated distorted mentalization, and the red is borderline, do they both move to the optimum with oxytocin? Or do some hypermentalizers increase the salience so they go over the peak of the curve? These are the kind of questions that are going to be important to resolve if we want to use these agents as potential enhancers, as people are doing now for treatment, for example, cognitive behavioral social treatments, because these things can be administered over a short period of time and can facilitate social interactions. And let me just take 2 minutes on cognitive impairment and schizotypy. This is another critical dimension. Dopamine can modulate working memory and executive function in cortex. And in fact, people with schizophrenia and schizotypal personality disorder may have deficiencies in cortex. We're developing paradigms to measure that now. We have temperamental precursors to people with schizotypy in motor and attentional spheres, and environmental precursors, childhood abuse and rejection. And we can show profiles of neuropsych alterations, and this is a laboratory behavioral paradigm that you can do to show that there are real cognitive differences Same pattern as schizophrenics, but milder, and no differences, though, with our other personality disorders when we control for working memory. So this seems to be driven by a relatively focal deficit in working memory, and we have some paradigms that can especially well capture working memory that involve errors where you can't hold a previous stimulus in mind. In interest of time, I'm not going to go into it in detail, but just show that, in fact, variations in COMT that have to do with dopamine are, in fact, related to this impairment. We found genotypes in the glutamate system and neuroregulin system in our schizotypals that are associated with schizotypal status and cognitive impairment. This is just some markers of prefrontal and temporal gray matter that are related to schizotypy. So there are structural differences. One final point, homovanillic acid is a metabolite of dopamine. More HVA gives us more psychotic-like symptoms, and this is just a displacement paradigm showing more dopamine release, and less HVA with more negative symptoms. So I'm not gonna go into some of the further finding, but there are findings in course, treatment response to dopamine agents like pergolide. We now have new data from a selective D1 agonist showing big improvements in working memory, increased from baseline, from the D1 agonist compared to placebo. And then let me come back to some of the main themes. I'm certainly happy to share more information on the schizotypals, but I think it may be less of a central interest to this group, but that what we're talking about is genotype interacting with environment to modulate brain structure and function, which interacts with differences in behavior and clinical syndromes, that improved systems of understanding and validating diagnostic systems may give us new treatments, may give us predictors of response to existing treatments. It may help us demonstrate critical mediators of response. So these are some of the domains we talked about: biomarkers, genetics, psychosocial antecedents, and actually you could do factor analysis of validators from multiple domains, and that may be a way to provide supporting validated data for diagnostic systems, so that if we can get a big enough sample size and we can pull in genetic data, neurobiologic data, psychosocial antecedent data, maybe we can see what kind of conformations or clusters of dimensions or diagnoses emerge. We tried this as work of Mike McCluskey in a very narrow dimension of impulsive aggression and found pretty much a single factor in self-reports for aggression and related factors, impulsive aggression, affective lability. We could separate them, but they all loaded highly together. On the other hand, in laboratory fact tests, we got two distinct factors: impulsivity, which is the hyperreactivity, and calculated aggression. And the other thing, caution here, is that when we used our laboratory test, PSAP, high correlation with borderlines with the actual physical aggression, but not so much in our other personality disorder patients, which include schizotypal, avoidant. When they became aggressive, it may not have been driven by the same reactive aggression. So different causes can change the correlational patterns in these kind of analyses. This is something we need to keep in mind. There are emergent properties as dimensions reach extremes. That is, aggression, affective. At a certain point, behaviors can become pathologic beyond the norm. Even though it's a continuous variable, the ultimate properties may emerge at certain inflection points, so that it's not just that the dimension behaves exactly the same at low levels and at high levels. Plus, we get interaction between multiple dimensions, affective instability, sensitivity to emotion, then interacts with the reactive aggression, which in turn causes more provocation. And there's complexity of comorbid diagnoses. So we have to take this into account. There are ways to do analyses, multiple indicators, multiple causes, which can actually look for latent traits. You can use genetics, you could use structural imaging to see, are there latent traits underlying some of these traits that emerge as disorder-like entities? Are they all independent? So with more data, and especially I think more validating data, though we won't have ultimate answers, we can take a better stab at actually thinking, how can we divide these disorders and how can we create diagnostic categories that conform better to the way nature actually works. And just want to acknowledge my multiple colleagues at Mount Sinai and elsewhere. Harold Koningsberg, Antonia New, and Mercedes Perez Rodriguez, you'll be hearing about here, Dan Roselle, Aaron Hazlett for the psychophysiology, Marianne Goodman, and Anissa Abidargam for the imaging. Thank you.